Hello, good morning, good afternoon, and good evening to everyone joining today Ask WHO session about COVID-19. Today's focus is vaccine and scientific updates on COVID-19 vaccines with our Chief Scientist, Dr. Soumya Swaminathan. Good afternoon.
Hello.
Thank you for being with us today. Before we start, I would invite our viewers to ask their questions if they are watching us on Twitter using the hashtag AskWHO. If you're watching us on other platforms, please use the comment section and I will pass your questions to Dr. Soumya. Unfortunately, we're seeing COVID-19 cases increasing in many places around the world, and these are mostly driven by Omicron sublineages BA.4 and BA.5. So what is the science telling us about effectiveness of current vaccines against these Omicron sublineages?
Yeah, thank you, Alex. I'm sure people are worried when they see these increases. And in fact, all of us know that in every country in the world today, I think we have friends and family and people that we know are infected. And we're starting to see a pattern now. So what we're seeing is that this Omicron is still the dominant variant of concern. It's been since November of 2021. But within Omicron, the virus has been changing and adapting and evolving in that it's accumulating new mutations. And that's what we call the subvariants or the sublineages. Each of them is a little bit different from the previous one, but enough for it to try to escape the immune response a little bit. So this is why every 3 to 4 months, countries are experiencing a surge. So if a country might have had a BA.1 or a BA.2 surge, starting in December, January, February, that's when we saw the first Omicron wave, and then there was a peak and it came down. A lot of people were infected at that time, and we thought that we all will have some amount of relative immunity. But because of these subvariants, we saw then, starting from South Africa, but now across the world, BA.4, BA.5, in some places BA.2.12. There are other sublineages emerging, causing these localized surges. Now, while the numbers are going up, I think the good news is that we're still not seeing that translate into hospitalizations of lots of people getting severely ill or dying. So, in fact, we were watching closely when it happened in South Africa. They had a big peak with BA.4 and 5, but it did not translate into people getting very ill and dying, and that's because of the pre-existing immunity. So even though our immunity is not preventing us from getting another infection, we're getting reinfected, even if we'd had a previous Omicron infection, even if we've had our vaccinations. But these vaccines are preventing us from getting ill. They're protecting us from getting severe disease. And so, to summarize, I could say that the vaccines are still proving to be highly effective, even against these newer variants. And that's something that, we have to be really grateful for, that the original vaccines that were developed are still doing a very good job of protecting against severe disease, but of course, not as effective in completely preventing infections.
Thank you so much, Dr. Soumya. And we're also seeing some concerning news today, reports from the news about a new Omicron sublineage being identified in India, and some reports saying how it's highly infectious and may have an immunity escape. So maybe you can clarify what is this new sublineage about, and what do we know from scientific research about it so far?
So the good thing about this expansion of genomic sequencing and the fact that everybody is sharing their whole genome sequences now, all countries are sharing on platforms like GISAID, allows us to have a real-time view of what is happening with this virus. Never before have the whole world, been able to watch a virus, constantly changing. And so as we do that, we see these new patterns of mutations emerging. And you're right that there's been an emergence of could be a subvariant. It's being not yet officially called, but some people are referring to it as BA.2.75, first reported from India and then from about 10 other countries. There are still limited sequences available to analyze, but this subvariant seems to have a few mutations on the receptor binding domain of the spike protein. So obviously that's a key part of the virus that attaches itself to the human receptor. So we have to watch that. it's still too early to know if this subvariant has properties of additional immune evasion or indeed of being more clinically severe. We don't know that. Luckily, the other subvariants of Omicron have not proven to be more severe. They've all been more or less like the original Omicron. So we have to wait and see. And of course, we are tracking it. And the WHO committees, the TAG VE, is constantly looking at the data from around the world. And at any time, if there is an emergence of a virus that looks very different from a previous one, enough to be called a separate variant of concern, then the committee will do that.
Thank you so much, Dr. Sumya. We're already receiving quite a few questions about vaccine, but there is one question about mutation of the virus. So maybe we take this one first from Mahdi Zarfi. Could we say that with more mutations, the virus would get weaker in aspect of infection?
So this is a common belief, but it's not correct. The virus does not necessarily get weaker. It could also acquire a mutation that makes it even more severe or more dangerous. However, I think what happens is that over a period of time, we've seen over the last year and a half since vaccines were rolled out around the world, and that there's been a lot of natural infection with Omicron, that the wall of immunity in the population is increasing. So that's what has changed. Even though the virus is also changing, but human beings have acquired immunity, and that's protecting us to a large extent. So as long as these vaccines still hold up as they have done till now, I think we're okay. And over a period of time, we expect that this virus will settle into a sort of what we call an endemic condition. When it's present in the population, it still undergoes changes. As you know, we have 7 known beta coronaviruses. 4 of them cause the common cold. All of us get common colds, once or twice a year. And so there are 3 viruses, the SARS-1, this one, the SARS-CoV-2, and the MERS, which cause very severe disease. But we'll have to wait and see how this evolves. And the most likely scenario is that it settles into this pattern of changing a little bit, causing an outbreak or a surge in cases, but hopefully not leading to the kind of situation that we saw in 2020 or 2021. And that's thanks to the immunity that we have acquired.
Thank you so much, Dr. Sumya. Veronica Douglas, watching us on Facebook, is asking, can WHO say how many COVID-19 subvariants are circulating that are vaccine resistant? I think you clarified that, but I think
we can say again, we have not seen any subvariant that is vaccine resistant. We still have over 80 to 85% efficacy of all of our vaccines, particularly if you've had the primary course and the third dose, the booster dose, then you're getting, over 85% protection against severe disease, against all variants.
Thank you so much. We've got questions from few of the viewers who are saying that they were infected and sick with COVID-19, and then they are asking when is the right time and should they get a booster dose after being sick?
So again, that's a good question, and there isn't a great deal of science. We know that hybrid immunity is very good. So if you've been vaccinated and then you've had a natural infection, then you get what we call hybrid immunity, which is makes your immune system strong. You can still have another booster. It's usually advised to wait for about 3 months so that you're fully recovered. And for about 3 months, your antibodies are probably pretty high as well. So after that, if you take a booster, then that will give you another increase in antibodies and higher protection.
Thank you. And some countries are providing already the 4th and 5th doses. So how effective are these? And how often should a person get a booster dose?
So again, these are questions that would need to be answered by good data. And as we are going, time is passing, we are collecting that type of vaccine effectiveness data from countries. But I must say that a lot of the data is on mRNA vaccines, and a lot of the data is coming from only a handful of high-income countries. So we really need all countries to start collecting data by age and by sex on people who are infected, and we need to know were they vaccinated or not. So just having a simple registry in the hospital and analyzing that data to see who are the people who are getting admitted in the hospital. Are they vaccinated? Did they have a booster? What is their age? This is what is going to help us to determine our booster policy for the future. For the time being, the WHO recommends that everybody get a primary course and a booster. That's a third dose. third dose, which really gives you very high level of protection. As you said, many countries have started giving a fourth dose. And that's because you see this waning of antibodies, particularly against Omicron. And so the fourth dose again boosts your immune system a little bit, but it's temporary. Again, the antibodies tend to wane. So our recommendation now is that fourth doses could be offered to those who are very highly vulnerable, so the elderly, people who have underlying medical conditions, people who are immunosuppressed, perhaps pregnant women, and those who are in very close contact at high risk of getting infected. So these groups of people could potentially be offered a fourth dose, especially like 4 to 6 months after the previous dose, because that then boosts the immunity. But again, that doesn't seem to protect against getting infected, but it could offer, of course, additional protection, a little bit incremental protection against severe disease. But it's not recommended for everyone at this point.
Thank you so much. We have one viewer who is saying that he received primary doses of one type of a vaccine, but that vaccine is not available anymore. So for a booster dose, do we recommend so-called mix and match of vaccines?
Yes, so there's enough data now to say that this is a safe and a good approach. So if you've had your primary course with one vaccine, you can get your third dose or booster dose with a different vaccine. You'll get just as good or maybe even a better immune response. So yes, that is very much possible. But of course, different countries have different policies. So it depends on where he or she is living.
Thank you so much. Rupali Sisir, watching us on Facebook as well, is asking which vaccines have more efficacy in currently circulating variants?
So again, the good news is that almost all of the vaccines have quite high efficacy, but the vaccine effectiveness studies have shown some slight differences. So the mRNA vaccines seem to offer the highest levels of efficacy, followed by the viral vectored vaccines and then the inactivated vaccines. But even the inactivated vaccines do very well when a third dose is administered. So vaccines like Sinovac and Sinopharm and potentially Covaxin also do well when a third dose is administered. And again, like I said, the booster dose could be the same, it could be a different vaccine. So I think we're learning that a third dose, a booster dose, actually really does good. It boosts the immune response. So at this point of time, I think any vaccine that's available in your country, the goal should be to get that and get the full course.
Thank you so much. We are getting some questions about vaccination of children. So maybe you can tell us what is WHO recommendation for COVID vaccines in younger populations. But there is a particular question about readily available vaccines for children in Africa.
Yes, so for children, there are a couple of things to think about. The first is that children can get infected just as commonly as adults, so children and adolescents. The good thing, of course, is that we've seen that they are much less likely to suffer from severe disease. But there are children who have underlying problems, and even a few healthy children who have become very severely ill, and unfortunately, some children have died. Again, very small numbers in terms of percentages, but every child's life is important. There are also things like post-COVID and long COVID, which can affect children just as it affects adults. It's less common in children, but there are many reports of children who have persistent symptoms. So we do want to protect children as well. Now, the WHO developed this prioritization roadmap where we said, we have to start by reducing deaths, and most of the deaths are occurring in the older age groups. So every country must prioritize that age group first, and then you come down progressively. And once you've covered your elderly and other high-risk groups, you're coming down to adults, and then you come to adolescents and children. It's of course also taken longer to get vaccines approved for children because the studies were all done in adults first. They were done very rapidly, safety had to be established, efficacy had to be established, and then the pediatric studies were done. 12 to 18 age group, 6 to 12 age group, and then under 6. There have been a number of vaccines approved by different countries for children. Not all of them are approved by WHO. So we have the mRNA vaccine, particularly Pfizer, and now more recently Mrna, which are approved for younger children as well. But many of the inactivated vaccines in China and India are approved for use in children, and also the Covovax vaccine, which is a so again, national policies are different. The national regulators are looking at the data, they're looking at the dossier and approving it, and national governments are determining their policies based on their epidemiology, their experience, and also what their goals of their vaccination program are. So there is that. I think there are differences from country to country in which children are being vaccinated, who's eligible. But now we know, for example, you do not need to vaccinate children in order to open schools and send them back to schools, for example. We do not need to restrict the activities of children if they are not vaccinated. So again, vaccination is important for those children who have underlying illnesses, who are more at risk of getting severe disease. Certainly those should be prioritized along with the adults with those kind of underlying illnesses. But for healthy children, it's really up to countries to decide when and with which vaccines they want to vaccinate.
Thank you so much, Dr. Sumia. We are receiving quite a few questions on side effects of potential side effects of vaccines, and there were a few questions about myocarditis and in COVID patients, but also vaccinated patients. So what do we have from data that we know about this condition?
So we know that the mRNA vaccines can cause myocarditis, particularly in young men between the age of 18 and 30. And the rates of myocarditis that have been reported from those countries that have very good systems for reporting, pharmacovigilance systems, are about, in the range of 4 to 6 per million. Now, if you compare that with myocarditis and cardiac problems that you can get after COVID infection, it's about almost 100-fold difference. So getting myocarditis after vaccination, very rare, can occur, and most of the cases have recovered completely with just symptomatic treatment. But getting myocarditis after COVID infection is much more common and can be much more dangerous. And we're learning now that some people develop diseases like diabetes and cardiovascular disease, like the risk is 2 to 3 times more if you've had COVID infection. So much better to protect with vaccination. And the myocarditis in most cases is mild and transitory. It subsides in a few days.
Thank you so much. Here's another question about potential side effect to clarify from Christina Betty. Is COVID-19 vaccine linked to shingles?
No, not that I have come across that association. Sometimes, there is a coincidence. You get a vaccine and then something happens to you the next day or a couple of days later, which might have happened anyway. So it doesn't mean that it's linked to the vaccine. But as far as I'm aware, there has not been any association between shingles and vaccine.
Thank you so much. Here is a next question from Mrna Nigan. If you could elaborate on a pan-coronavirus vaccines and as well as the next generation of COVID vaccines.
That's a very good question because of what we've been saying, that the vaccines, though we have today, are very good, but they're not preventing us from getting infected. And we don't know if they'll protect us from another very different variant. So the goal of scientists is to create a pan-coronavirus vaccine. What does that mean? It means that it will protect against not only SARS-CoV-2, all variants, but it could also protect against some of the other beta coronaviruses. Coronaviruses are one of the most common viruses in the animal kingdom. And it's not just bats, but a number of other animal species which carry coronaviruses. And this is how in the past and now we've seen SARS-1, we've seen MERS, which are circulating in animals, and then they are able to jump into humans and cause disease. So there's a high likelihood that we may have another pandemic due to a coronavirus in the next decades. So the research on pan-coronavirus vaccines has really accelerated over the last 2 years because people have realized that this is a real threat for the future. And I would say that now there's a very good chance, luckily, the coronaviruses seem to be easier to make vaccines than, say, influenza or HIV. And so the chances of getting a pan-coronavirus vaccine, I think, are high. Scientists are using a number of different approaches. One is mRNA. We're all familiar with mRNA vaccine currently, using the spike of this particular virus, the Wuhan strain, the original strain, and now, companies are now adding Omicron variants also and making bivalent vaccines. So you can imagine that an mRNA vaccine could have the parts of the spike protein from different coronaviruses, and that way you could create one. You could also have nanoparticle-based vaccines where you take, again, different pieces of the protein from different coronaviruses and put it on a nanoparticle. So you have nanoparticle-based vaccines. You could have also approaches for inactivated vaccines where you take a bunch of different viruses, you culture them, you mix them, and then you create an inactivated vaccine from that. So I think the research is going on which parts of the spike protein should be taken, which will stimulate the immune system the most and create a very broad protective immunity. So I think some companies, in fact, have already announced that they're starting clinical trials. So I believe that in the next year to 2 years, we will see a lot of advance, and ultimately that may come as a solution for us when you take a course of this vaccine, and hopefully it protects you against multiple coronaviruses for a long period.
Thank you so much, Dr. Soumya. We're having also questions about the vaccine solidarity trials, and when can we expect some preliminary results from those?
So, WHO started the vaccine solidarity trial a few months ago when we realized that we need to continue to invest in research and development of new vaccines. We are not done. And I think Dr. Tedros, our Director General, made a very clear statement last week also saying we need to continue to invest in research and development even as we scale up the use of existing vaccines. So the solidarity trial started with one vaccine in 3 countries. What we do is we put out, any company can come to us with the vaccines that they have. It goes through a committee of experts, what we call the prioritization committee. They look at all of the data and recommend to WHO whether to include that vaccine in the trial. So I'll give you a very exciting piece of news, and that is that the first vaccine, nasal vaccine, will go into trial in the Solidarity platform. Hopefully, starting in July, we have all of the approvals in place. That should happen in many countries in Africa and Latin America. And it will, we're excited because I think that nasal vaccines, mucosal vaccines, could have an added advantage of protecting against infection as well as against severe disease. So maybe a combo of an injectable vaccine and a nasal spray could be very effective in protecting us. It's also possible that people who cannot take injections or are scared of injections will be more enthusiastic about taking a mucosal, just a nasal spray or nasal drops. So we have at least 3 or 4 nasal vaccines that are being developed, and our committee is looking at others to include them. So we should have an update on that. So the Solidarity trial is active. It's still enrolling people. Of course, now the challenge is you don't have a lot of unvaccinated people in many countries, and so we need to modify the study design to look at how well these vaccines can protect against symptomatic infection.
Thank you so much, Dr. Soumya. We have a question from a viewer that in the new vaccines that scientists are working on, can you please confirm that the vaccine will have nothing to do with CRISPR technology? CRISPR.
So I wonder what prompted that question. So CRISPR-Cas9 technology, the co-inventors, Jennifer Doudna, Emmanuel Charpentier, won the Nobel Prize a couple of years ago, has revolutionized the way in which in the way in which gene therapies are done. And it's basically a tool. It gives you a tool to make a very specific genetic change, because you can hone in on the part of the genome that you're interested in, and basically like a pair of molecular scissors, you use it to cut that segment and replace it with something else. So it's being used very widely across research now, across a whole range, particularly as I mentioned, gene therapies. And so it's just a tool in the hands of scientists. And so I don't think we can say that particular. So far, the vaccines have not used that technology, but it could be in the future that it's helpful to modify the gene that you want to use, and it could be used in vaccines. But I don't think it's anything to worry about.
Thank you, Dr. Sumya, for clarifying that. We also received an interesting question from Mrna Negan, who is watching. There was another question as well. We often use a line that vaccines save lives. So the question is, will vaccines always be the ultimate tool protecting us against future epidemics or pandemics moving forward?
I would say definitely one of the tools. As we've seen, it's not the only tool, because despite using vaccines, we've still had people who get infected, get sick. So we still need the drugs. You need the public health measures, what we call the non-pharmaceutical interventions, the masks and so on. But, if without vaccines, we'd have been in a very different and difficult situation just now. We would not be sitting here and talking to each other like this. So I do think that vaccines offer us the best hope for future pandemics. But also, I think we have renewed enthusiasm and optimism now to create vaccines against diseases like tuberculosis, like malaria. The WHO just approved, the first vaccine against malaria a few months ago, which offers about 40 to 50% protection. We should do better than that. There are diseases like HIV for which we do not have a vaccine. Even influenza, there's potential to improve. So I think the field of vaccinology has really accelerated. The science behind vaccinology and immunology and virology, all of that has really improved in the last 2 years because of all the additional funding and all the additional scientists who turned to this new challenge when we had COVID. So I'm optimistic that we're going to have better vaccines. I think the biggest scientific achievement of the 20th century is vaccines. It's what keeps us all alive and going, and has reduced child mortality. And I just want to say that one very worrying trend we're noticing is a reduction in childhood vaccinations in many countries because of COVID and the burden on the health system. Childhood vaccination rates have dropped, and we are getting reports of diseases like diphtheria, horrible illness in children that can kill children, and measles from countries which did not have diphtheria and measles outbreaks in the last couple of years. So we really we have to take our hats off to healthcare workers. They've been under tremendous strain. They've done their best, but we do need to make sure that our routine immunization systems for children are also strengthened and kept up.
Thank you so much, Dr. Sumi. And as you said, you believe that vaccines are one of the main tools to protect us against various diseases in the past, in the present, and in the future. But there are other tools. And there was a question we received about the pill for COVID-19 that's produced by Pfizer. One of the viewers was asking about its effectiveness and how people can access it, and when is the right time to get a pill.
Yes, so we've been tracking, treatments for COVID, and again, it was very good to see this drug, nirmatrelvir and ritonavir. It's a combination drug. It's called Paxlovid, produced by Pfizer, which showed very high protection from progression. So if you take it in the first 3 to 4 days of being infected, then you can actually prevent your infection from getting worse. So it's recommended. WHO recommends it for people who are at high risk, again, with underlying illnesses or if elderly, etc. But it's challenging to implement because of a couple of things. One is it has to be linked to testing, and we've seen many countries are reducing testing. They are reducing the availability of free testing. So it's very difficult then for people to get tested, get diagnosed, so that they can access the treatment. On the other hand, in some countries, we've seen programs to link testing and treatment. That's what we would like to see. You should be able to go to a health center if you have symptoms, get tested, And if you qualify for treatment, get the drugs right there and then, go home with your pills, which you take for 5 days, and that should protect you even further. There has been issues with access. We've been trying to work with Pfizer to make sure that the drug is accessible across the world, that it's affordable, that it's not too difficult for countries to get the drug from Pfizer, to purchase it. And they've also provided license to a number of generic companies, but those companies will not deliver till 2023. So again, we're hoping that Pfizer will really come forward and work with with our partners who procure these drugs, for especially for low and middle income countries, so that we can provide access. At the moment, unfortunately, access is limited to this drug, but we hope that more people can, because it can also save additional lives on top of vaccines.
If something we learned in this pandemic, that equitable access of tools, whether it's
Yes.
vaccines or pills or tests or masks in certain moments,
Exactly.
is really a challenge. Maybe I'll take two more questions before we close. It's around studies for vaccines. One is from Rima Attar. Are vaccines being studied on transmission as well as immunity? Previously, symptoms were the main areas being studied, and the public were initially led to believe that vaccines would stop transmission. It wasn't until after a certain amount of vaccines were taken up that this data was offered to the general public. So maybe we can clarify of what we knew about the effectiveness of COVID vaccines in the beginning.
Yeah, it's a good question, because the first clinical trials did look at symptomatic infection and also at severe disease, and we found these vaccines were very effective, protecting against severe disease and to a lesser extent against infection. But when Omicron came, it changed everything, because what happened is that Omicron had enough changes in its genome to be able to evade that existing immunity, and so it could cause infection much more easily. It could come in and get attached to our receptors and also spread much more quickly. So with each variation of the SARS-CoV-2 virus, its transmissibility has been increasing. So this is why now the understanding that the existing vaccines are not protecting us fully from infection. So it's not that it wasn't that it was hidden in the beginning. It wasn't that. It was just the virus has also changed itself, and so the protection has changed. And this is why we need these nasal vaccines, mucosal vaccines, pan-coronavirus vaccines. So we have to keep trying to improve the efficacy. So ultimately, you want to also try to block transmission as far as possible. But we know that for a number of other diseases as well, the vaccines actually work by protecting us from getting severely ill, not by blocking transmission. So the perfect should not become the enemy of the good. We should use what we have, because what we have is excellent. But at the same time, we should continue the investing in the research to develop even better vaccines.
Thank you so much. And here is a question as well from Rima. Have you carried studies on people with compromised immune systems, and how long the vaccines protect them for?
So again, a very good question. And the studies that have been done, there are few studies that have been done in immunocompromised people. They need additional doses of the vaccine, and this is why very early on we recommended a third dose for immunocompromised, and then a fourth and potentially even a fifth dose, because for immunocompromised, the primary course itself is 3 doses instead of 2. So 3 plus, so the fourth dose would actually be the booster for them, and then you may give an additional dose. About the duration of protection, I think it's almost the same as a non-immunocompromised, but again, those studies need to be done, and it depends, which patient group you're talking about. But if you take HIV, for example, they seem to have very good response.
Thank you so much, Dr. Sumi. And maybe as we reflect, we are in the third year of the pandemic. We got vaccines developed faster than ever. We got now treatments and many tools at hand. How do you see the whole public health and health science work being developed in future and from now on, whether it's for COVID pandemic or for other diseases?
Yes, so I think this is an area where clearly we've learned so much that we should not let our experience be forgotten or go to waste. And so for me, the big learnings are that science needs to be at the heart of our response to health, to public health, whether it's pandemics or whether it's other threats to our health, non-communicable diseases, air pollution, all of these have solutions that will come from science and scientists. So investing in science, investing in scientists, investing in research, giving young people opportunities to take those careers, that's going to be very important for me. The second is, I think, the global collaboration that we've seen in whether it's the sharing of data on genome sequences, whether it's the clinical trials that many countries came together and did solidarity trials, and whether it's the hundreds of expert groups that WHO runs where everyone comes together, private sector, public sector, to share information, share data so that it can quickly have impact on the public. That spirit should continue. And I think the fourth area is probably how do you communicate the risks? How do you communicate? Because these are topics sometimes where you don't have the perfect answer and the perfect solution. And so we've learned also through the pandemic, and governments have learned how to communicate with the public, how to be as transparent as possible with the data, how to communicate the knowns and the unknowns, and then make decisions based on risks and benefits. All the time, these two have to be weighed, and the decision making must also involve voices from the community. We have to listen to what people are saying. We have to listen, and certainly WHO, we've tried our best to have these kind of engagements with the public, with journalists, with ministries, with scientists, to listen to all views and take them into account. And yes, I would certainly hope that these lessons are now applied to all other aspects of health.
Thank you so much for your time today and for very good answers. And of course, to all our viewers for their questions and for watching us from Tanzania, Bangladesh, Iran, Ukraine, Zambia, Italy, Turkey, South Africa, Greece, Bulgaria, the US, Mexico, Ethiopia, Niger, Rwanda, Malawi, Cameroon, Dominican Republic, Brazil, and many others. Thank you for your questions. Thank you for being with us, for listening to us. And also, I think I want to read one comment before we close from Mahdi Mohammed Sahal, who says, I'm a medical doctor in Somalia. We vaccinated so many patients in Somalia and no side effects seen yet. People should take the vaccine. So I think this is the right message to close this conversation today. So if you haven't had your doses, please get them as soon as you can, and stay safe. Practice the rest of the measures as well. And until next week, follow us on our social media channels or for updates on the website. Goodbye.
Bye-bye.